Okay, we'll be discussing this case which came to us obviously during COVID times, and we had to make certain modifications to, adjust as per the requirements of COVID. So this is a young girl, 26-year Miss SB, and she was presented with bleeding per rectum and constipation for 1 month. And she presented to us in month of December, late December, and she underwent usual evaluation, and colonoscopy was done, which suggested adenocarcinoma. And when we further evaluated her, we got a PET CT done as per the routine protocol. Ankit, can you play the PET CT scan films? Ankit, can you hear me?
Yes, I'm playing them. I'm playing them.
Yeah, I hope this is, I think you guys can appreciate what I'm trying to show here. So it's a lesion in the sigmoid colon and going up to just touching the rectum, and there was some deposits in the cul-de-sac, and there were lymph nodes around the iliac vessels, external iliacs, right? And young female with a peritoneal disease. As per preoperative evaluation, decision was made to give her a neoadjuvant chemotherapy, and followed by reassessment after 2 months of treatment, that is 4 cycles of Folfox. So as per the plan, she underwent 4 cycles. Next slide, please, Ankit. So as per the plan, she underwent 4 cycles of chemotherapy. And by the time she was finishing her treatment, this was, next slide, please. So this was precisely the time when COVID came to our lives. And all of us were flabbergasted. We didn't know how to deal with this. We were confused, and so were the patients, and young female and the relatives. They got very panicky. They were not sure whether they want to go ahead with surgery. So they again came back to us. They asked us, is there any other viable option? Is it possible for us to delay her surgery for some time so that they can make up their mind? And so case was again discussed in the tumor board, and we gave her, she was reassessed, and again a scan was done which showed good response, and there was about 30% metabolic and anatomical response on the restaging. So the decision was made to give her 2 more cycles of Folfox, just because patient and her relatives were not willing for surgery at that particular time. So this adjustment was made precisely for COVID, so that a surgery could be delayed at a more suitable time. So, next slide, please, Ankit. Yeah, yes. So she received another 2 cycles of chemotherapy, and after that, a further reassessment was made. And can you show the next CT films, Ankit? The other one.
Sure.
Yeah. So is it the first one or the second one?
The first one.
Yeah. So this is the pre chemotherapy images. If you can see, it's a big tumor, and there's a lot of haziness in the pouch of Douglas. There's no free fluid and no peritoneal disease, no disease anywhere else. Can you show me the next scan, please?
This is the post scan.
Yes. So this is the post scan. Yeah. So this is the scan which was done after the completion of 6 cycles of chemotherapy. You can see there is a good response to chemotherapy. Tumor has regressed by close to 50%, and the nodes which are along the external iliac vessels have regressed as well. There is no deposit anywhere else in the peritoneum other than the lower quadrants, and rest of the intra-abdominal viscera and bowel looks absolutely free. So the next plan was to take her up for surgery. The surgery that this girl would be requiring was an anterior resection with cytoreduction with HIPEC. Now, again, the challenge in front of us was whether to do a HIPEC during COVID times. There was actually very scarce data. We were not very sure whether by doing a HIPEC would we be subjecting her to an additional risk of infection during this time. There was other considerations as well, like she's a young girl, a low volume disease in the peritoneum. Her PCI was only 5, and the only chance of cure or definitive possibility of cure was to go with aggressive management of complete cytoreduction and HIPEC with anterior section. After due deliberations with all the onboard team with medical oncologists, surgical oncologists, and the radiation guys, and taking patient and the relatives in confidence that yes, extensive surgery with HIPEC and a prolonged duration of hospital stay, it might, the extra duration of hospital stay might land her in a additional risk of having a COVID infection in perioperative period, but this is possibly the only chance of cure for her. So she underwent a complete anterior resection with complete cytoreductive surgery and HIPEC. Next slide, please. So we had to, we made 2 modifications. Yeah, so this is the completed procedure, and this is how surprisingly surgeons look like in COVID era. They look more like astronauts than surgeons. But yes, so we had 2 dilemmas in this patient. One, she actually landed up for treatment exactly at the time when COVID came to our lives, and we were very unsure of how to deal with this. And second dilemma was whether to subject the patient to a very extensive surgery with a possible comorbidities and a treatment which could prolong her hospital stay by a few days. So was it worth a risk? So this is how we managed this particular case. And I think for this, there's one more case for the discussion, and probably we can take up all the questions and all the literature review after we have finished the 2 cases. Is it okay, sir? I mean, you think that's the fair point, or we want to discuss this case first?
If there are few questions
and
now,
we can discuss few cases related. So I invite all my GI medicine and gastrosurgeons and surgeons on board if they have any specific question to this case. I can see the chat box. There are particularly questions from our team as well, and happy to have any questions from the people on board. So as Dr. Harith asked, Asit, what was your initial plan for neoadjuvant chemotherapy? What do you practice? I mean, in practice, how many cycles you give? I think there's a Foxtrot data which was published last year, ESMO, which clearly said that patients can be given neoadjuvant chemotherapy. They do not have inferior survival if, as we compared with surgery upfront. So how many chemotherapy were planned from your side? Had it been a non-COVID era?
So,
am I audible, Ankur? Hello.
Yes, you can. You are audible. You can.
Okay. So when we evaluated this case first, if you have noticed the scan, in the scan there was already peritoneal metastasis. So this disease was not just a locally advanced CA sigmoid colon; it was a metastatic CA sigmoid colon with peritoneal disease. But it was a low volume disease. PCI was close to 5 to be precise, right? So the plan was to give her neoadjuvant chemotherapy, like you said, to 4 cycles, that is 2 months of treatment, and then reassess and then take up for surgery if there is a good or favorable response or a stable disease.
Yeah. So usually in neoadjuvant chemotherapy, we prefer 4 to 6 cycles, but in resectable colon cancer or GI cancer, we usually prefer 4 cycles. And doing imaging after 2 months, there is a data of adding targeted therapy, which can be anti-EGFR or anti-angiogenic, which is like beyond this topic. So we clearly advise 4 cycles of chemotherapy, but because of the COVID era, because of the inhibition and because of the atmosphere around us, the patient took 6 cycles, which was 3 months of perioperative chemotherapy, and her CT scan showed good response. I would also like to discuss very important issue. So how you dealt with fertility? She was 26, unmarried, a young female. Was fertility discussed? And I would like my other experts, medical oncologists on board, Shefali, Bhavna, and Sandeep Batra to chip in. How do you deal such patients? Will COVID matter with fertility, or you have to treat this patient like as you're treating in non-COVID era?
Yes, fertility, this has to come in discussion. And if you can see this slide, preservation of oocytes was performed in this patient as well. This was discussed in depth, and this is something which is, I believe, mandatory for all patients in this age group. And secondly, I would like to add one more point. I mean, I don't know whether it's fair to call this patient neoadjuvant chemotherapy. It was probably a pseudo neoadjuvant because it was metastatic disease to begin with. But yes, fertility preservation is, I think, one of the most important yet neglected area, and it should be given due importance.
So I would like to again re-emphasize on this term neoadjuvant or pseudo neoadjuvant. In colorectal cancer, if my all gastrosurgeons are with me, in colorectal cancer we have when we have isolated liver metastasis or when we have isolated peritoneal metastasis, even this stage 4A. Stage 4B is when we have more than 2 visceral organs. Even in stage 4A, when the disease is limited to liver or the disease is limited to only peritoneum, still our intention is cure. With this neoadjuvant chemotherapy and with HIPEC, we can still have a good 20% 5-year survival benefit. So intention of cure was in this patient. That is why we were aggressive even in COVID era. So one more thing, Asit, I mean, she was 26, she had no family history, I can see on the slide. Was genetic counseling done? Is this patient worth discussing this aspect also? Because 26 colorectal cancer is rare.
Oh, yes. And this is something which requires detailed assessment. And we are very lucky we have Dr. Amit Verma amongst us. And all such patients are duly referred to somebody who is a specialist in this and who can do a complete analysis, preoperative assessment, and genetic assessment of these patients. Yes, it needs to be done. This is something.
So this is very important. We cannot forget this part. This is our social responsibility, dealing with the other family members and actually calculating a risk factors for the siblings and the future generation. I hope there are no there are specific questions which can be taken. Dr. Bhavna, can you comment on this case? Till now, everything going fine? Neoadjuvant chemotherapy followed by surgery? I think Bhavna is not online. Dr. Sandeep Batra?
I think in the context of the COVID, increasing the number of cycles from 4 to 6 was a wise decision. As well as the oocyte preservation, we did not forget that in the COVID era also. So to me, it looks like a perfect management of this patient. So I will be interested to know what happened after the surgery, what has been the final histopathology report, and so as to plan the further treatment.
So Dr. Sandeep, this is post-operative day 4. This is a real case which has been operated last Saturday or Friday. So today is Tuesday. This is post-operative day 5. Patient is doing very well in post-op ICU and recovering very well. I can see Dr. Munshi raising his hand. Dr. Munshi is a very senior clinician in now, Dr. Munshi, can you ask your question, please?
Ankur, just to let you know, Dr. Munshi and we were together in school.
Wonderful, sir. So we have cumulative 200 years here.
Hi, Munshi, how are you? Thanks for chipping in. Yeah, great.
I think we cannot hear him right now. So if there is no further
I'm
more
very
questions.
happy. Can you hear me?
Yeah, we can hear you, Dr. Munshi. Please go ahead.
Yeah, actually, I'm very happy to be here. Harith had invited me. We have been school friends. I'm very happy with the progress of the case, and I have no questions as of now. I'm just enjoying the trip. Thank you.
Okay, great, Dr. Munshi. Thank you for joining in. And
Ankur, I wanted to make a point.
Yeah,
Ankur,
sure.
I wanted to make a point.
Sure.
So while I agree with the extension of neoadjuvant chemotherapy, because we know colorectal cancers are inherently very chemosensitive, but I would always put in a word of caution when it comes to extending chemotherapy across all indications, because you need to look at the chemosensitivity of a particular disease and you have to balance it against the immunosuppressive effects of chemotherapy. So while surgery is a one encounter or a few days encounter, chemotherapy can be multiple days encounter. So it needs to be individualized for each patient.
Very well said, Devrat. Very well said.
Ankur,
So
even I have a point. If this patient had true aggressive disease, would you have chosen FOLFOX-Series as the preferred modality, or you would have continued with the FOLFOX?
Yeah.
Remember, this patient was started before the COVID-19 pandemic hit. Now,
exactly.
there are two questions out of this. If you were planning FOLFOX-Series and then the COVID-19 came in, would you have continued with the FOLFOX-Series, or you would have shifted to either FOLFOX or FOLFOX?
So I would like to answer this question. So certainly, yes, in pre-COVID era, I would like to add FOLFOXIRI, the three drug regime. She is too young and she is a resident of Delhi, so there is no logistic support. I knew this family very well. So a 3-drug regime has to be given in a young patient who has got an aggressive disease. 3-drug versus 2-drug and a targeted therapy. There is a data, but there is no data of using cetuximab and bevacizumab extensively in pre-HIPEC setting. So yes, I agree with FOLFOXIRI in the pre-COVID area, but particularly in COVID era, when the incidence of neutropenia, the incidence of infections happening in this COVID area, it's a difficult emergency to deal with. The hospitals are actually full of COVID patients here and there, and difficult triage also. So certainly in COVID area, I'm very happy with FOLFOX, but in pre-COVID area in 26-year-old, I would not go for FOLFOXIRI, but it's a personalized decision. Even there are some guidelines to it that we should go selectively for these patients, and happy with 2-drug, but I'm not denying the 3-drug if personalized approach can be given to this patient. So any other question related to this patient? Otherwise, we can move on to the next case. I think there are no more questions. So,
Dr. Ankur, can I make a comment here?
Sure.
So there are some guidelines which also say that you can maintain the continuum of dose intensity and dose duration with the help of GCSF support. So I think, as you rightly said, after discussion with the patient's family about the effect of FOLFOXIRI and continuum of this regimen in the COVID era, so we can also discuss about the granulocytes colony stimulating factor support, and once we are going radically, I think this option should also be discussed in this context.
Yeah. So I think Sandeep will cover this, the medical oncology perspective. How can we manipulate? How can we extensively use this aggressive dose dense regime and higher protocols? And I think if there are no more questions, we can move on to the second case. Asit and Sanjeev, if you are here, we can again have a presentation on the second case. Over to Asit and Sanjeev again.
Yeah, Dr. Sanjeev, I'm transferring the. I'm transferring control.
Okay, thank you very much, Dr. Ankur. So I'll be moving to the next case. So Ankit, I'm not able to change the slides.
Okay.
No, it's not happening. So you have to control from your side.
No problem.
Okay. So the second case is again an interesting case. 48-year-old gentleman, good performance status, doctor by occupation. Next. So in December 2017, he presented with acute abdomen and he underwent laparoscopic appendectomy. Appendix was perforated. HPR revealed low-grade mucinous neoplasm. He took no further treatment. Next slide. March 2018, he again presented with plain abdomen. Imaging revealed peritoneal nodules in the right ilia fossa and the pelvis. So he was operated elsewhere and he underwent CRS, which included right hemicolectomy with HIPEC. Final HPR showed appendicular carcinoma in situ. No further treatment was given to him. Again, November 2019, his spleen abdomen record, there was loss of weight and loss of appetite. He was evaluated for the same. Next. So the CT scan revealed, if you can appreciate, a deposit on the second part of the duodenum and also on the right kidney. Next. So there was disease, peritoneal nodules, mostly more in the pelvis, in the rectovesical pouch, and on the bladder, and also on the seminal vesicle. Next. So MR was done. Here we can see the disease lying in the rectovesical pouch, deposit on the rectum, and also on the bladder. Anteriorly, there was a central deposit which was involving both the seminal vesicles. Next. So there was perirectal nodes, and you can see a big presacral node. Tumor markers were highly elevated. CA was 34 and CA 99 was 1200. Biopsy revealed adenocarcinoma. So he received 4 cycles of Folfox. His radiological PCI was 6, and he was given 4 cycles of Folfox with bevacizumab. Later, he received 2 cycles of Folfox. Response assessment. He has symptomatic improvement. His pain subsided. He regained his appetite. Markers normalized. So PET showed the deposit on the duodenum resolved, and also, but the deposit on the kidney was the same, and there was also deposit on the transverse colon and mesocolon. Next. So there was disease in the pouch of Douglas and on the bladder, and the deposit in the seminal vesicle was there. Next. So we can see. So this is on the bladder and this is on the rectum. Next. So response assessment. He had a good response in terms of clinical response, serological response, radiological response, and metabolic response. Next. So the plan was redo CRS HIPEC. We use our clinical acumen and sound judgment to decide what is best for the patient. But sometimes what is obvious is not right, and what is right is not obvious. So we did not offer this patient redo CRS HIPEC. Next. And he was given further chemotherapy. Next. So why we did different? Because this was a difficult time. We are not only dealing with the disease, but also dealing with a pandemic. The quantum of surgery was large, both in terms of duration of the surgery and extent of visceral dissection. This patient would have otherwise required pelvic exenteration, also transverse colectomy with duodenal excision, which would result in more blood loss, requirement of post-op ventilation, and increased complication. So whether to do CRS HIPEC, yes or no, in this COVID setting? This is a big question. So this is the recent guidelines from the French Rene group, which is our largest network. So they have mentioned, make no recommendation for prioritizing chemotherapy over surgery or over no therapy based on COVID-19 risk and implied mortality. Next. So we have to give priority to young patients with limited peritoneal disease. Systemic neoadjuvant chemotherapy can allow cytoreduction surgery to be delayed, and HIPEC must not increase the risk of post-operative complication. Next. So similarly, SSO has mentioned same. So CRS HIPEC is a unique procedure which requires a unique level of resources, and special considerations should be made before proceeding with the cases. So there should be proper selection of cases. Next. So these were the tale of 2 cases where we have learned what not to do. As a surgeon, when we involve, everyone knows that what not to do. But during COVID time, we should also understand and know when not to do.